Hi, my name is John Allen. I'm a clinical assistant professor at the University of Florida College of Pharmacy, and this presentation is about inhaled nitric oxide and its role in the treatment of COVID-19. Nitric oxide is a molecule that is endogenous to the body and is associated with multiple biological functions. Nitric oxide acts as a regulator for several different processes in the central nervous system, immune system, and cardiovascular system, respectively. Nitric oxide also acts as a potent vasodilator in smooth muscles. There are multiple drugs that act on the nitric oxide pathway or themselves serve as nitric oxide precursors, leading to a pharmacological effect. Abnormal nitric oxide concentrations have been associated with a number of disease states. For example, COPD is associated with elevated levels of nitric oxide, while chronic kidney disease is associated with decreased levels of nitric oxide. There has been in vitro data that suggests nitric oxide inhibits SARS-CoV-1 replication, which makes it an attractive option when we're investigating whether it has a role in COVID-19. Inhaled nitric oxide has been investigated and used for a number of pulmonary disorders that we'll review in a few slides. With regards to the mechanism of action of inhaled nitric oxide, it is rapidly diffused across the alveolar capillary membranes to pulmonary smooth muscle. Once at the pulmonary smooth muscle, this leads to activation of guanylate cyclase, which in turn increases cyclic intracellular concentrations of cyclic GMP. This in turn leads to pulmonary smooth muscle relaxation and ultimately increases in partial pressure of oxygen and decrease pulmonary vascular resistance. Because it is rapidly metabolized and not absorbed to a substantial amount, there is a relatively minimal impact on systemic vascular resistance. Inhaled nitric oxide has been applied for a few different pulmonary conditions, including acute respiratory distress syndrome, ARDS, pulmonary hypertension in both adults and neonates. In ARDS, it is used primarily for pulmonary vasodilation and has been associated with increases in oxygenation and increases in PaO2 to FiO2 ratio. However, those improvements in oxygenation have been transient increases. Inhaled nitric oxide, based on a recent Cochrane review, does not appear to have any impact on overall survival, ventilator-free days, quality of life, or ICU or hospital length of stay, respectively, and thus it is not frequently used in the treatment of ARDS. In pulmonary hypertension for adults, inhaled nitric oxide can be used in a diagnostic way, such as in pulmonary vasoreactivity testing, to help guide clinicians to the types of therapies that may benefit particular patients with pulmonary hypertension. Or it can be used to treat pulmonary hypertension, most notably perioperatively in patients who require cardiac transplantation or those who require the insertion of an LVAD. In neonates with pulmonary hypertension, it has been used for a number of different indications there, and those are included on the slide for your reference. There are a few adverse drug reactions associated with the use of inhaled nitric oxide. The first is methemoglobinemia, which occurs as a byproduct of the breakdown of nitric oxide. Additionally, when patients are weaned too quickly from inhaled nitric oxide, you can see deterioration of oxygenation status, signaling a need for continued mechanical ventilation. Pulmonary edema can develop, particularly in patients who have left ventricular dysfunction. Rebound pulmonary hypertension, as stated previously, can occur if there is too rapid of a weaning process. Acute renal failure can also occur. It's hypothesized that this is due to reperfusion injury. And there is a theoretical increased bleeding risk because nitric oxide itself can inhibit platelet adhesion and aggregation. With respect to mechanisms of inhaled nitric oxide in COVID-19, Pulmonary vasodilatory effects as well as bronchodilator effects are most prominent because we know that with severe COVID-19 that acute respiratory failure is a major manifestation. Additionally, anti-inflammatory as well as antiviral properties that have been associated with inhaled nitric oxide make it an attractive option for the treatment of COVID-19. Before we can talk about inhaled nitric oxide in COVID-19, let's take a look back of inhaled nitric oxide in the treatment of SARS. Chen and colleagues presented a report of the use of inhaled nitric oxide in 2 Chinese hospitals. The study was non-randomized and non-blinded. It looked to investigate patients with SARS, adult patients with SARS who had greater than 1 week duration of symptoms. And patients required PaO2 to FiO2 ratio of less than 300 or an oxygen saturation of less than 93% or requiring an FiO2 of at least 50%. The inhaled nitric oxide regimen was started on day 1 as a continuous inhalation at 30 parts per million and was titrated over the next 4 days. Inhaled nitric oxide was resumed if the patient experienced deterioration in their oxygenation during the weaning process and was restarted on their previously tolerated regimen. Patients were also on concomitant therapy of ribavirin as well as methylprednisolone. The study included 14 patients, 6 in the inhaled nitric oxide group and 8 in the control group. Duration of symptoms for patients included in the study were 32 days in the nitric oxide group and 25 days in the control group, indicating that these patients received therapy later in their disease course. Ventilator support was needed in most of these patients, with 5 out of 6 in the nitric oxide group and 6 out of 8 in the control group. With respect to the use of inhaled nitric oxide, it was associated with improved oxygenation and decreased FiO2 requirements as compared to control. Oxygen requirements decreased from a baseline of 6 liters per minute prior to inhaled nitric oxide to 2 liters per minute of oxygen during inhaled nitric oxide therapy, while the control group did not change. FiO2 requirements also decreased from 70% to 50% during the same time frame in patients who required inhaled nitric oxide or who received inhaled nitric oxide. This effect appeared to persist after inhaled nitric oxide treatment, indicating that potentially there are other benefits of inhaled nitric oxide beyond the pulmonary vasodilatory effects. It should be noted that there were no differences in hospital mortality. However, this is not a surprise due to the small sample size. 1 patient in the inhaled nitric oxide group died and 2 patients in the control group died. Moving forward to our experience in COVID-19, and the first report of inhaled nitric oxide in COVID-19 comes from a single center, Mass Gen in Boston, and they looked at in a non-randomized, non-blinded case series the use of inhaled nitric oxide in pregnant COVID-19 patients. The requirement was that patients had to have respiratory distress due to COVID-19, and the actual inhaled nitric oxide regimen used varied based on oxygen requirement. Moving to the actual nitric oxide regimen itself, those who required low amounts of oxygen, in this case defined as less than 3 liters per minute, received a regimen of 200 parts per million for 30 minutes twice a day. Those who required more oxygen, greater than 3 liters per minute, received a continuous regimen as well as an intermittent regimen. And inhaled nitric oxide was started within 48 hours of hospital admission for all patients. 6 patients were included in this case series, ranging in age from 24 to 33 years of age, which is much younger than patients who are typical patients with COVID-19 who develop severe disease. Symptom duration ranged from 3 to 14 days, and as compared to the previous literature in SARS, these patients received inhaled nitric oxide much quicker in their disease course. Disease severity, 2 patients were listed as severe, defined as a respiratory rate greater than 30 and the presence of lung infiltrates on chest radiography. And 4 out of 6 patients were critical, which was defined as the presence of severe respiratory distress, shock, or multiple organ dysfunction. A third of patients, 2 out of 6, received remdesivir with a duration of therapy ranging from 3 to 7 days. It should be noted that data on the use of steroids was not reported in the study, and given the known benefits of steroids in severe ARDS, or severe COVID-19, excuse me, these patients, the data is limited in the absence of that data. In terms of the actual dosing and number of sessions, you can see those listed on the slide for your reference. In terms of the results, the patients who received inhaled nitric oxide did experience improved oxygenation, and this was most prominent in patients who had the lower baseline SpO2. It was reported that there was a subjective relief of shortness of breath with the use of inhaled nitric oxide, and there was a decrease in respiratory rate that was observed. However, this was transient and subsequently returned to baseline after discontinuation of inhaled nitric oxide. It should be noted that patients treated with inhaled nitric oxide also experienced decreased levels of C-reactive protein during and after inhaled nitric oxide, and that persisted until hospital discharge, illustrating a potential anti-inflammatory effect. And baseline and peak methemoglobin levels were similar, with baseline being around 0.9% and peak being 2.5% respectively. The investigators attempted to keep methemoglobin levels less than 5%, which was achieved in this study. Shifting gears a little bit to Zananaman and colleagues, who reported on the use of inhaled nitric oxide on an outpatient basis for a 34-year-old patient with pulmonary arterial hypertension who later developed COVID-19. The patient lived 350 miles away from their pulmonary hypertension center, and the decision was made to provide the patient with an ambulatory inhaled nitric oxide delivery system to her residence. The patient was also provided with remote monitoring and home assessment over 6-minute walk distance, which is an assessment that's used to evaluate the effectiveness of pulmonary hypertension treatments. The initial regimen of inhaled nitric oxide was 20 parts per million plus 2 liters per minute of supplemental oxygen, and this was delivered via nasal cannula for 12 to 14 hours per day. Overnight, this was gradually weaned to 0 parts per million and then was eventually restarted in the morning, each morning. On inhaled nitric oxide days 7 and 9, the inhaled nitric oxide regimen was titrated downwards. The patient was started on inhaled nitric oxide and remained on nitric oxide for 11 days. And throughout that treatment, the patient had normal methemoglobin levels. It should be noted that the patient experienced symptomatic improvement as evidenced by improvements in her WHO symptom classification. At baseline, her WHO symptom classification was class 1, which are the mildest symptoms. During her development of COVID, her symptoms worsened, and then with the treatment of her COVID-19 with inhaled nitric oxide, you can see that her symptoms improved over time. Additionally, we saw an improvement in her 6-minute walk distance test, as indicated by the blue line on the figure here. And during treatment, her 6-minute walk distance increased to nearly 80% of her baseline. Additionally, decreases in her emphasis 10 score were observed during inhaled nitric oxide treatment, Emphasis 10 score is a quality of life score, with higher scores indicating worsened quality of life. So that decreased during the course of therapy. The patient did not require urgent care, emergency medicine, or a hospital visit during inhaled nitric oxide treatment. It should be noted that this patient was a physician, and so this may limit its broad applicability. But I think it does highlight that with proper patient selection and monitoring, inhaled nitric oxide could be an option on an outpatient basis. Now let's make sense of the noise that we're seeing with relates to inhaled nitric oxide and COVID-19. Inhaled nitric oxide appears to improve oxygenation transiently. It does appear to be relatively safe, as there were no reports of any safety problems in the COVID-19 reports. It should be noted, though, that inhaled nitric oxide is an expensive therapy, with reports denoting that it is $100 or more per hour for therapy. And with many of the therapies reported being continuous in nature, it can be very expensive to implement this regimen. Some questions that we don't know about the use of inhaled nitric oxide include: does it actually improve clinical outcomes? I would present to you that based on the ARDS data, the answer is no. However, we need studies to validate that finding. Also, we don't know if there are specific subsets of patients who may benefit from inhaled nitric oxide. For example, does starting earlier in the disease course provide benefit as opposed to starting later in the disease course? Additionally, does the use of inhaled nitric oxide as a means to wean a patient from the ventilator, is that helpful, versus as a means to prevent an actual intubation? And so investigating specific subsets might be helpful for us to understand the specific role of inhaled nitric oxide, if there is one. Additionally, because of its expense, a cost-benefit analysis needs to be completed, and further investigation of its anti-inflammatory properties should be warranted, particularly based on seeing decreases in anti-inflammatory markers that were observed in COVID-19 patients. Also, it remains to be seen if analogs of nitric oxide might be also beneficial, and we just need more evidence to support that claim. There are several different ongoing clinical trials as it relates to the use of inhaled nitric oxide in COVID-19. There are 7 trials in the U.S. Most are occurring in the Boston area at Mass General, but there are other U.S. centers that are participating as well. The table below indicates the U.S. studies that I found on clinicaltrials.gov, and you can see there's a wide variety of dosing as well as delivery method. Additionally, there is variety in terms of patient population, whether it be used for treatment of patients with severe disease or prevention of the actual development of COVID-19. One study that I do want to highlight is the phase 3 study looking to investigate the use of inhaled nitric oxide in patients with COVID-19 who require supplemental oxygen. This study is known as the COVANOX study and aims to enroll up to 500 patients to either inhaled nitric oxide or placebo at 14 hospitals in the United States. The primary endpoint will assess the number of patients that have respiratory failure or mortality. This study design follows the release of preliminary data from the drug device manufacturer that demonstrated patients treated with inhaled nitric oxide had a recovery rate of 73% and mortality rate of 6.3% at day 14 of treatment, and was generally well tolerated with no safety concerns reported. However, the lack of a comparator group, as well as the lack of this data being published and only being available through press release, limits our applicability of this data and makes us eagerly anticipate the results of the COVANOX study. There are clinical practice guidelines that discuss the use of inhaled nitric oxide in COVID-19. Specifically, the NIH guidelines recommend against the use of inhaled nitric oxide, and the rationale is because uh, the estimation is that ARDS that is caused by COVID-19 is not uh, very different as compared to ARDS caused for other reasons, and we know that inhaled nitric oxide is not a standard of care for patients who have ARDS. Additionally, the Surviving Sepsis campaign released guidelines on COVID-19, and again, they recommend against the routine use of inhaled nitric oxide. However, they do provide a caveat that notes that in patients with severe ARDS who are mechanically ventilated and remain hypoxic despite optimizing therapy, they suggest using a trial of inhaled pulmonary vasodilators, such as inhaled nitric oxide, as a rescue or salvage therapy. However, they do admit that this is a weak recommendation and is based on low quality evidence. At present, the IDSA does not address specifically the use of inhaled nitric oxide for the treatment of COVID-19. Some clinical pearls with respect to inhaled nitric oxide. It can be safely delivered via multiple methods, including a face mask, nasal cannula, or via an endotracheal tube. The ideal delivery system, which most current contemporary systems use, have synchronized delivery with respiration and produce minimal amounts of nitric dioxide. Additionally, contemporary systems have alarms and allow for precise monitoring of nitric oxide, nitric dioxide, and oxygen, respectively. Institutions that utilize nitric oxide oftentimes have guidelines for use to describe specific indications, who can write for the actual product, specific monitoring parameters, team roles and responsibilities, as well as weaning parameters to prevent rebound pulmonary vasoconstriction. And I would present to you that that generally is considered a best practice. In summary, inhaled nitric oxide is a promising agent in the management of COVID-19 based on theoretical benefit. However, the information that we have is not robust, and we need more evidence to support widespread use. At this time, inhaled nitric oxide can't be recommended for routine use, but there are several trials underway to investigate its use. I would recommend that if you are considering using inhaled nitric oxide as salvage therapy, this should only be performed at centers with previous experience using inhaled nitric oxide who already have guidelines in place for use. And with that, that closes my presentation. Thank you for your attention.